Hi, my name is Jason Brophy, and on behalf of the team of EPIC4 research investigators, I'm very happy to present today. The title for my talk is Neurodevelopmental and Mental Health Comorbidities in Canadian Children and Adolescents Living with HIV in the EPIC4 cohort. This is my conflict of interest slide. Perinatal HIV infection differs from an infection later in life in that it can affect the developing brain. In the past, we saw high rates of developmental delay and HIV-related brain disease like HIV encephalopathy in children and adolescents living with HIV in the era before we had good treatments and earlier treatment initiation. Likewise, mental health diagnoses have previously been described as being more common in children living with HIV. Limited data exists on the Canadian population, but treatment guidance has certainly changed a lot over time, and earlier treatment is now the rule, and these may hopefully impact these outcomes in a positive way. The current study aims to describe neurodevelopmental and mental health diagnoses in the Early Pediatric Initiation Canada Child Cure cohort, or EPIC4. EPIC4 is a multi-center prospective study that involved 9 pediatric HIV care centers across the country. And the objectives of EPIC4 were to assess the impact of early combination antiretroviral initiation on both the size of HIV reservoirs in children and the evolution of the infection and development of the immune system, including HIV-specific immune responses and chronic inflammation in children. The inclusion criteria for a subject to be in EPIC4 were that they had to have perinatally acquired HIV-1 infection, and they were excluded if they had HIV-2 infection or HIV-1 infection by a route other than perinatal infection. We learned a lot of great new information on HIV reservoirs from EPIC4, but it's worth noting that the clinical and laboratory data collected as part of this study allow us to answer lots of additional types of questions about Canada's cohort of children living with HIV. And so the objective of this study and today's presentation were to review our EPIC4 database to determine the prevalence of neurodevelopmental and mental health diagnoses amongst children living with HIV in Canada, and to investigate predictors of these diagnoses. For EPIC4, subjects were prospectively enrolled at sites across Canada, and health records were reviewed at baseline for clinical characteristics, including timing of diagnosis and timing of treatment initiation, HIV viral load suppression rates, CD4 counts, and nadirs in particular, and additional HIV-related and unrelated diagnoses. Subjects were followed over a 4-year period of time from 2015 to 18, and new incident diagnoses were collected along with clinical and HIV outcomes at 4 study visits per year, which were timed with routine clinical appointments. Frequencies of neurodevelopmental and mental health diagnoses were calculated, and univariate Poisson regression analyses were performed to determine risk factors for these diagnoses, accounting for age at baseline. What were our results? Out of 226 children and adolescents enrolled in the study, the median age at diagnosis was 1.4 years. The median age at the last study visit was 15.6 years. 53% were female and 56% were born outside of Canada. 41% were diagnosed at less than 1 year of age, and almost 50% had a peak viral load greater than 100,000 copies per ml. 2/3 were Black race, 10% were white, 9% were Indigenous or Aboriginal, 10% were Asian or Arab origin, and 4% were other. From an HIV characteristics point of view, 1/3 of children had a worst CDC immunologic stage of stage 3. 29% had a worse CDC clinical stage of stage C, which is the most advanced stage. And with respect to age at CART initiation, 30% initiated CART at less than 1 year of age, 32% at 1 to 5 years, and 34% at greater than 5 years, and 4% had not yet initiated therapy. With respect to neurodevelopmental diagnoses, we found that 25% of subjects in the cohort had one, including language delays with expressive delays at 12% and receptive delays at almost 11%. motor delays, including gross motor at 10% and fine motor at 10%, and global delays at 10%. HIV encephalopathy had been diagnosed in 8.8% of people in the cohort. Head imaging had been performed in 35% of subjects, and amongst those who had head imaging done, 70% of them had an abnormality detected. This leads to an overall statistic of 25% of children in the entire cohort having abnormal head imaging, which is similar to the rate who had a neurodevelopmental diagnosis. 16% had a learning disability, including almost 4% with dyslexia, 1.4% with both auditory and visual processing disorders, and almost 11% with an unspecified learning disability. 13% of children in the cohort had failed at least one grade in school. Mental health diagnoses were diagnosed in almost 29% of individuals in the cohort, including 13% with ADHD, nearly 11% with depression, nearly 11% with anxiety, and nearly 5% with post-traumatic stress disorder. In our analysis of predictors of these diagnoses, the predictors of neurodevelopmental diagnoses included prematurity with a relative risk of 2.5, diagnosis at less than 1 year with a relative risk of 2.2, earlier CART initiation with a relative risk of 3.8 if CART was initiated below a year of age, and a relative risk of 2.0 if initiated at 1 to 5 years of age. Higher peak viral load over 100,000 copies with a relative risk of 1.7. More recent year of birth with relative risk of 2.1 when born between 2005 and 2009, and a relative risk of 4.1 if born after 2010. And the plus, or proportion of life under viral suppression, with a relative risk of 1.13 per 0.1 unit increase in the proportion. The predictors of mental health diagnoses were very similar to those for neurodevelopmental diagnoses, including prematurity, diagnosis at less than 1 year, CART initiation at less than 1 year, more recent year of birth, and the proportion of life under viral suppression. In addition, the CD4 count nadir was also a significant risk factor, with a relative risk of 0.92 per 100 cell per microliter decrease in the nadir CD4. So in our study, we found that the rates of neurodevelopmental diagnoses and mental health diagnoses in Canadian children living with HIV are suggestive of a higher burden. The rate of learning disabilities was 16% versus a rate of 3.2% in the general population in Canada. The rate of ADHD was higher, with our rate of 13% versus a published rate of 5 to 6% in Canadian children and adolescents. And our rate of anxiety at 11% was higher than quoted rates of about 4% in Canadian adolescents. Interestingly, we found similar rates for depression and post-traumatic stress disorder as published rates in Canada and the US. But I think it's worth noting that many of the available statistics reflect an estimated true prevalence of these conditions, including those who remain undiagnosed. And so the fact that the numbers of diagnosed cases in our clinics are equal to or higher than these published estimates suggests an even higher burden in children living with HIV in Canada. Some of the predictive factors we identified were expected. Prematurity and higher viral loads would be expected to have an association with neurodevelopmental and mental health diagnoses through direct brain effects. But some of the predictive factors were non-intuitive, such as early CART initiation less than a year and proportion of life under viral suppression, because one would expect that earlier treatment and longer viral suppression should be neuroprotective. However, those children who were diagnosed earlier may have been more likely to have been diagnosed due to symptoms, including neurodevelopmental symptoms. Likewise, those diagnosed later in life may have been more likely to have had long-term non-progression, especially children who migrated to Canada from lower resource settings. The more recent year of birth was also a non-intuitive risk factor for poor outcome, because with better ARVs that are better tolerated and easier to take, and more liberal treatment guidelines in recent years, one would have expected better outcomes. However, this may reflect unmeasured risk factors. For example, we know that most transmissions in recent years that happen in Canada are among children born to women who are not engaged in care and who had intravenous drug use as an HIV risk factor. And these factors, not having prenatal care and being exposed to in utero to illicit drugs, are known risk factors for poorer outcomes in children. There are a number of limitations to this study. One is that we depended on passive reporting in HIV clinic records, and this may well be incomplete, particularly if diagnoses of mental health and neurodevelopment were made outside of the HIV clinic setting and may not have been available for review. The numbers we feel represent diagnosed cases, and active screening with specific tools for neurodevelopment and mental health would likely yield even higher numbers based on the available literature about children living with HIV in the US and other developed and lower resource settings. We were unclear on the in utero infection status of most of the children in this cohort unless they were diagnosed at delivery, and this is a known predictor of poorer neurodevelopmental outcome. Treatment details were certainly lacking in most foreign-born children, and so we don't have clear ideas about the timing of diagnosis and initiation of therapy, except from verbal report from the parents. There were a variety of treatment strategies over time, and this makes it difficult to understand the temporal trends. For example, CD4 thresholds in the past were used to decide on initiating therapy in children, just like in adults, whereas in the last 5 years or so, we've moved to immediate treatment for all children. And lastly, maternal substance use was not collected as part of the EPIC-4 data collection CRF, and we know that this is a major contributor to neurodevelopmental risk. So, in conclusion, I think we can safely say that neurodevelopmental and mental health diagnoses are prevalent in children living with HIV in Canada, unfortunately. And this is something that we need to recognize and put additional protections and services in place for. We are planning a mental health survey of adolescents living with HIV in Canada to try to screen for the true prevalence of mental health disorders. And we are planning knowledge translation and exchange through CPARG, the Canadian Pediatric and Perinatal HIV/AIDS Research Group, to try to raise more awareness of the burden of these problems in this population. And with that, I'd like to thank the funders of EPIC-4, CIHR, CANFAR, and the International AIDS Society, and also to acknowledge the significant support we've received from the Canadian HIV Trials Network and the Public Health Agency of Canada during the conduct of this study. This is our list of investigators. This is our list of acknowledgements. And we'd also like to specifically thank all the children and young adults who consented to participate in this study. Thank you.